Okay. Heliotherapy. That means treatment using the light from the sun. It's been used for many centuries and many different cultures, essentially just for health and well-being. Well, let's come a little bit more recent. The 19th century, they made a big thing about health treatment. See this, Our Friend the Sun, Images of Light Therapies from the Oslo Library. Davos, that well-known place for meetings in the early winter with the financial kings of the world, it framed itself as the capital of light and air therapy in the 19th century. They had several luxurious sanatorium, lots of space for lying in the sun in the fresh mountain air, as you will see on the bottom picture here. Whoops, there we go. And for some people who were less affluent, there were other ways of delivering the sun to large numbers of people. Now, until the end of the 19th century, people weren't very interested in the science of how light might be helpful in medicine. But there was one guy who really made his mark in that area. He knew that at the end of the 19th century, people could kill bacteria with ultraviolet light. And he started to think, well, maybe I can use that in other areas as well. And you'll see this device on the top right here. It's a device for delivering ultraviolet light to tuberculosis, which was commonly involved the neck and the nodes there. But he did it so well that he was awarded the Nobel Prize. So he was pretty happy about that. But in terms of appreciating light and ventilation, many of you who may know London's University College Hospital will see in this picture on the right there that it's built in the shape of a cross. And they said for light and ventilation, and the essential thing was you could have light down both sides of every ward who were in the arms of that. Now, at that time, things looking at light in medicine were being explored in other countries. And one that really hit the headlines, although it didn't hit the headlines till much later, was in Munich, where there was a medical student who was looking at paramecia and say these are single-celled ciliated protozoans up to about 0.5 millimeter in size. They're found in freshwater like ponds and lakes. And it's not at all clear why he was looking at them. But anyway, for some reason, he decided he had this little water container that he could see them going around in. And he added some dye to that, which was actually acridine orange. And this was what he was seeing. This was looking down, and you watch carefully. Do I have pressed the button hard enough? Don't think I have. Oops. Minor hiccup. Sorry. It should show the paranecia wriggling around, but I'm afraid it doesn't seem to want to. So we'll move on to the next stage. The point is that he moved his microscope from the dark corner where he was working. He thought, perhaps I'll go over to the window where the sun has started shining. And what happened was that all the wiggling little creatures stopped wiggling, and suddenly the penny dropped. This is an effect which required the combination of a chemical, in this case acridine orange, and the light. Each of them on their own didn't work, but the combination did. And basically, this was the birth of the concept of photodynamic therapy, the mixture of a chemical and light. Now, he's very ambitious. He looked harder at how this worked, and there had to be some oxygen around to get this reaction to work of drug plus light. And he was very brave in some of his experiments. He even thought he could treat people with cancers on their face. Well, I think he was very brave to do that, though we don't know too much detail of the experiments. But anyway, tried. But after this, lots of people thought this is something worth exploring. But there were many people trying to do this in different ways. And somebody relatively recently said, I'm going to draw a tree of PDT development. And if you were able to see the little branches, which I appreciate you're not, it's all the things people tried. But I'm going to jump forward literally 70 years to bring you up to the stage where PDT was really starting to hit the headlines. This was presented by a guy called Tom Doherty. It was at the Roswell Park Memorial Cancer Institute in Buffalo, New York. Now, he had created a sensitizer. And a sensitizer means a drug that is activated by light. He called it hematoporphyrin derivative, and I will refer to it here onwards as HPD. He tried it on a model of mice where he'd injected a small concentration of cancer cells and watched them spread. And he found that when they've given HPD, that HPD was taken up selectively in the cancer. He thought, hang on, this looks interesting. And so he treated them a little more vigorously. And presto, that little area of cancer disappears. So that was the second part. We start with photodiagnosis, because you could excite fluorescence in these tumours with the HPD. And then photodynamic therapy, when the combination of drug and light and oxygen was actually providing a treatment. The principle was really quite simple. You could give the drug to the creature or whatever you were treating, wait for it to distribute in the body, and then apply light. In the early stages, you didn't need a laser. And he also worked on the actual mechanism of what was happening. And the idea was that the light activated the photosensitiser to a singlet state. And by various interactions then, ultimately, it converted ground state oxygen to singlet oxygen. And that was the ultimate cytotoxic agent which killed cells. Now, people got excited that this might be a new approach, a concept, drug by light could kill cancers. But most of this research was not done by the clinical people, it was done by laboratory people. And they focused on the mechanism of PDT, the chemistry of photosensitizers, and the response of tumours, with little consideration of what actually happened to a cancer, other than in that immediate area of the cancer. And as soon as the clinicians started to look at that, said, hang on, so many people have said we're going to have selective treatment of cancers. Are we ready to get that here? And nobody had looked at the biology of what this treatment would do to normal tissues, rather than just cancer ones. So the next big challenge was to find out what happened to normal tissues. Then you could ask yourself the question, when can we use this principle to treat a human disease? And then ultimately, the most difficult one is, we think this treatment will work in this condition. Can we actually deliver it? Well, people started doing this on skin cancers. And look at a small skin cancer here at the left-hand end. It's a small lesion. There we are. You can just sort of clean it up a bit. Then you put the photosensitizer on as a cream and just something to cover it while it's being absorbed in the tissue, and then shine light. Now, in this simple situation of the skin, the light could be fairly broad spectrum of wavelengths, and it was fairly simple to deliver. And of course, treating a skin lesion, you're unlikely to run into big trouble, whereas you will if you go into internal veins. But let's show some of the effects with the skin. This is a very simple one, but here's a case called actinic keratosis. It's a thing that's induced by prolonged exposure to sunlight in areas that are not not covered by anything. And you will see the rather unpleasant-looking picture on the left. After the PDT, which had the cream and the light, it's a beautiful cosmetic result. Now, let's get a little more sophisticated. This case, you've got a similar sort of tumor of the skin, but it's in a very difficult place because it's over bone and nothing else. Now, what happens with PDT, that area that looks like the nasty cancer, it's got some cells which are cancer cells, and those are living cells. But like all tissues, there's some connective tissue, like collagen, which provides the mechanical strength of that tissue. Now, PDT destroys those living cells, but not the underlying scaffolding of the tissue. And that means the PDT there can clear the cancer cells, and then normal cells can grow in from the adjacent normal tissue. With most of the other ways where you may treat skin tumours, operating them, excising them, chemotherapy, radiotherapy, you don't get that selectivity between the living and the dead bits. And because of that special function, that is why you get such good cosmetic results here. This is the equivalent thing on an old lady's skin, which again is the lesion of the skin and nothing underneath it apart from bone. Now, there are many skin applications of PDT for reasons other than cancers have been explored. And PDT is the best established practical application of PDT in modern clinical practice. And I'm not going to go into great detail of that, but talk about the more interesting ones, from my personal point of view, which are what happens when you try and use PDT internally. Now, remember with PDT, you've got to get the drug, the photosensitizer in your target area. You've got to get to that target area. And when you get there, you've got to get the right color light there. Now, first picture here, this was the same time at the beginning of the 20th century. People were looking at ways of getting an internal disease without all the trouble of open surgery. And these gentlemen, well, inspecting a body to see which regions might have access to internal organs. Well, obviously, what came after this was endoscopes. But just to finish this little bit, if you can get up a hollow tube inside the body, it may get you to a lesion, but then you've still got to get the right sort of lights there. And I'm going to talk about the ways in which both are done. First, a bit of history on endoscopes. Couldn't resist showing you these. At the beginning of the 20th century, you didn't have any flexible fibers that you could put light down. So if you wanted to look inside, it had to be in a straight line. And if you just think about the human anatomy, the only hollow organ that you can get into really through a straight line is the bladder. And so they had this straight tube, look into the bladder. But of course, you needed some light. And you'll see a sophisticated light source here, one candle. And the light was reflected. You could look through the tube inside. Next stage, paraffin lamp, doing the same, light, chimney for the paraffin lamp. And then sophisticated days of electricity. You could make a little bulb that fitted in the bladder. One little snag, it got hot. So you had to have pipes to pipe water in, keep the bulb cool, and drain it out again while you were looking and inspecting him. Well, that was all a bit of a hassle. And that stage, the only other organ it was easy to look in straight lines was the intestine. Unfortunately, it's only a small community where this is suitable for sword swallowers. But all endoscopes, you're probably familiar with endoscopes now. They're much easier, much more efficient. Typically, they're flexible. They've got their own light sources going in, so you can have light at the end to show you in white light what you're looking at. And that will give you a picture inside hollow organs. But here we come on to the laser side of this presentation. Now, in my generation, and probably many of you here as well, the first encounter with a laser beam was the James Bond film. And here James was certainly feeling rather threatened by this. But for those who don't know too much about lasers, just a couple of slides to show you what a laser light is and what the relevance is to medicine. First of all, you get an intense light beam. You can get it in a single color. And if you want light that's going to be absorbed by a photosensitizer, you need to match that light with the absorption peak of that sensitizer, which you can do with a laser. It's easy to control the beam very precisely. And even more important, you can focus that beam on a very small tip of a flexible fiber. And that fiber can be well under 1/10 of a millimeter in diameter. Now, the beauty of that is that if you've got a fiber like that, it can carry light through an operating channel of an endoscope. And here, up here, is the sort of fiber you have. This is a flexible fiber, which has got all those suitable coatings so that the light goes round bends. And the tip is designed so that light comes out in a circumferential array, so you can illuminate the wall of a hollow organ. Now, if you look, this is what you would do if you want to treat Sorry, there's a flexible endoscope, and you can have this fiber going through the operating channel there. This is a typical laser you can use for this sort of procedure. But if you want to get light into solid tissue, it's a much bigger challenge because you can only get the light from the tip of a fiber onto a surface. And the way of doing it, which we'll look at in more detail as we go along, is you can put multiple needles into the skin under image guidance, maybe CT or MR scans, put a laser fiber through, and then you can get light distributing within a solid tissue. Now, this, of course, is going to depend on how far the light will go through the tissue. So this is a comparison of, this one is chicken muscle, and this one is liver. And this is red light. And you'll see if the red light goes in there, it can diffuse quite a long way in the tissue. And you can expect to get an effect up to 10 or 11 millimeters deep in that tissue. In the liver, it doesn't go nearly as far. And any limit there is only going to be 2 or 3 millimeters. And of course, it depends on the color as well. Because if you look in the bottom slide, what happens with the same sort of power delivery, but blue light, it diffuses much less. So if you want to get laser light diffusing through tissue, you need to do it in a tissue that transmits light well, and you've got the right wavelength, which typically is in the red and the near infrared. Right, that's the background. Now let's get on to actually how we might treat somebody. As I've said, it's common sense. If you can get an endoscope in, you see things under white light. And so you could treat lesions that are arising in the wall of a hollow organ. Now, I'm going to talk about these 4 organs, the bladder, the intestinal tract, airways, and mouth. And the basic structure of the walls of those organs is similar in all of them, although the relative sizes of each vary. And you see, this is the lumen where things go through, whether it's urine, air, food, etc. The top layer is the mucosa. This is where all the metabolic activities happen. And it is a fact that all these hollow organs, this layer is vulnerable to the development of cancer, early, what we call a dysplasia, which is an abnormality, which may go on to cancer. There are various reasons for this happening, which I'm not going to go into, but the point is, it's the top layer where it happens. The next layer down, it's like a sort of interfloor service field, because you've got blood vessels which feed all the other layers, which they wouldn't work without it. And you've also got collagen tissue, which are not actually live cells, but they provide the mechanical strength of the organ. And then right at the outside of these walls or hollow tubes, you've got the muscle layer. And that's what helps things move along that channel. Now, if you've got these changes, they occur in the mucosa, these premalignant changes. So what you would like to do if you're treating them through the endoscope is you just destroy that top layer. And the effect of PDT on that top layer in the normal and that in the precancerous condition is remarkably similar. And this is a point very much worth noting. We said the talk from Buffalo, New York, was that you needed selective destruction of the cancer. Well, what you're actually looking for here is selective destruction of the mucosal layer, whether it's normal or diseased, and protecting the underlying layers. So it's selectivity between different layers of normal, not just between tumour and normal. But the beauty is, if you can destroy the lesions in the mucosal layer, the abnormal ones, then they heal up very well by regeneration of normal tissue. Now, the other thing is, if you're looking at hollow organ, potentially there are 2 risks. If you produce the full thickness effect, you might perforate it, and that's obviously very embarrassing. But fortunately, all the lab tests say that PDT does not do that. The other thing is, if you destroy all the layers, then there's a risk of scarring there, and that may cause obstruction, which is more of a problem. And we'll come on to how that is actually addressed. Now, let's start with one organ, this one where they had the very first endoscopes to look in. And this is a bladder. Typical story might be a patient comes in saying, "Doctor, I've got blood in my urine. I'm terrified." And very often the first test will be looking a catheter in, a modern one, nice flexible one, thin one, and that is the picture you might get. Now, can you see any evidence of anything abnormal in that? You can see various blood vessels going here and there. Well, obviously you can't. And until relatively recently, the only thing you could do to see whether there was tumour there at an early stage, of course an advanced one would be more obvious, you take little bits of tissue, send them off to the laboratory, and the pathologist has to tell you whether it's normal or tumour, and then you map out where the abnormal bits are. But what about photodiagnosis? How can we do better to find out the normal and the abnormal bits? Now, the first thing with the photodiagnosis, it's usually appropriate that you illuminate in blue light and the abnormal areas come up red. And this is exactly what happened in this bladder. You can see the red bits are dysplastic areas and the blue bits are normal. Now, this is wonderful. It tells you which bits to treat. Now, somebody who read that this selective destruction really happened, they said, if that's the case, why don't we treat the whole bladder with PDT? And they did. And oh my goodness, disaster. What happened? They got full thickness scarring in the bladder wall, the bladder shrunk down, and the poor old patient couldn't hold more than 50 mils in his bladder. Now, clearly that's a disaster, one of the first warnings. But you can treat focal lesions in the bladder, you could treat the red bits, because in those areas you don't mind if you get a full thickness effect. It's a little scar. It's only the whole thing that you have to be careful about. PDT to the bladder surface risk constriction, focal PDT is promising. Now let's go on next, and coming to the lungs. Now lungs are obviously very vital structures, and when feasible, lung cancers, you operate on them and remove them. But very often, the toxics that form the cancer in the first place leave that you get little bits left behind, or they can recur at later dates. And you'll see in one, this is a patient who had actually had one lung removed, so he only had one lung left, and so one of these was blind, although I'm not absolutely sure which one, and these little bits are a recurrent tumour. Now, what the PDT is aimed to do this is to destroy that relatively thick area of tumour. It may scrape off the surface of the mucosa as well, but it doesn't matter because it can all heal up again. So you can shine red light at that. This is the tip of the laser fibre, and it's missing this red light in a pattern focused on those areas. And when that's had a chance to heal up, you see it's essentially back to normal. Yes, there is a little nodule there, but biopsy of that showed that it was no longer tumour. So this is very promising. It's treating a relatively small volume, but it's treating it in a situation that's otherwise difficult. And I'm going to get this patient to tell you a little about his own condition. In the year 2000, he had a lung removed for cancer. 7 years later, he came back for review, and he was found to have that little recurrence, as you saw in the last slide. Now, you had to ask, are you going to treat that? He was unfit for any more surgery. He'd had some radiotherapy and chemotherapy, but as you may know, both of those have the effect of cumulative toxicity. If you give too much of them, everything falls apart or does nasty things. One of the beauties of PDT is that you don't get this cumulative toxicity. So it's very useful for picking up these little bits of tumour where there's nothing else that is feasible for them. Now, I'm going to get him to tell you his story himself, and I sincerely hope it's going to work now.
Yeah. So what became of me after my PDT treatment, as you can see, I'm alive, well, and got a good quality of life back again. Well, the first thing I noticed, I could breathe. 18 months ago, I was told I'd probably got a year to live. And here I am, 18 months later, as you can see, still going strong. I'm thankful to Dr. Jeremy George and his team at UCLH. Even more grateful that there is such a thing as PDT. Really, I was so shocked when Dr. George had to get permission to spend the money on the drug that saved my life, when I could have gone for, I don't know, chemotherapy, which cost 5 times as much. This whole thing really doesn't make sense to me. how much have you people heard about PDT? And if it was your lung cancer in your life, would you want to know about it? I feel sure you would.
Well, 4 years after that, we were honoured to have a visit from the Prince of Wales, as he was then, and we were able to introduce him to patients with diseases in 5 different specialties who'd had PDT. And here was Don, who's been wonderful about coming to meetings and letting us tell his story, and indeed telling it for himself. And as you see, he got 6 years extra life that he wasn't expecting. Now, let's come up a bit, come up to the mouth. This is a way of demonstrating in a bit more detail what the PDT does. This patient has 2 little lesions on his lip, had a diagnosis to see what they were, and they were cancer. So PDT was chosen. And here is the application. This is the laser, this is the fiber. The sergeant is just holding the fiber by hand. Now, one thing to note, when you see these pictures with bright laser treatment for PDT, the light that is doing the job is red. But the cameras, if they are receiving light that's too intense, they just record it as white. So what is being treated is actually pure red light. Now, let's look what happened. You can see it's fairly straightforward. Safety, you need goggles. The power used for one is typically about 1 watt. And if you think about the power of a laser pointer that you'll all be familiar with, it's only about 1 milliwatt, 1,000th of that. But if you're using a laser just to deliver heat effects, then it's another order of magnitude up again, and you may be up at 20 or 30 watts. But anyway, let's see what happened to this guy. Look at 4 days. If you weren't familiar with this, you might say, oh my God, quick telephone call to the medical defense unit, what have I done? But be patient. Move on, see what happened at 1 month. It's healed up beautifully. And all you see is the little scar there. That's where he had the biopsy to prove the diagnosis. But the lip here is regenerated. And it's the same thing that we killed the cancer cells, but we left that scaffolding in the tissue so it can heal by growth in of normal cells. And really none of the other techniques work quite as well as that. Now, I'm taking you on a little adventure, and I'm taking you off to Eastern India. Mouth cancer in India, as you may or may not know, is the commonest cancer because they choose to chew the carcinogenic agents instead of smoking them, which we do in Europe more often. Now, even the things that these are sold in, just as us, they're warned it's going to cause cancer, but they still do it. But the evidence, after they've chewed it, they have to get rid of the bits that left. And this is the traces they leave on the pavements, these little spots of red, which is rather unpleasant, but very common. Now, they are developing screening clinics to detect cancers like this at an early stage. And this is an example of one of these clinics. And they're done in rural villages where patients are very reluctant to rush off to a big city hospital until it's too late to help them. And this was regarded as an urgent need for an effective, low-cost diagnostic and treatment facility that can be delivered in these remote areas. This was a project that was funded by the US government, and it is actually a 3-nation project. Boston, where it was set up, and their first stage was to develop a light source just with LED and fix a fiber to that. So you've got a flexible fiber that could be used for treating a patient in the mouth. And that's actually quite an achievement because you can't focus the LED light as easily as you can laser light. And this was the first version of an LED light source with a fiber. Estimated cost, $500. Slight improvement, that was done with a laser, maybe $10,000, $15,000. Big difference. So the first phase of the project is to get the light source. Secondly, which again required a lot of ingenuity, is to modify a mobile phone to assess the extent of tumour in the mouth by fluorescence. After administration of the photosensitiser, which in this case was ALA, and then to treat some of these patients and see how we get along. Well, all went well for the stage. Well, this is the next stage, modification of the standard iPhone. Now, what was done here, you had this device plugged into that, which had this ring of blue LEDs, and that was to provide blue light to excite the fluorescence in the tumour in the mouth. And then this red filter over the camera in the phone, because all we wanted to look at was the fluorescence from the tumour in the mouth. And this looks like when it's actually been used on a patient. You can see the blue is the exciting light, and the red is the fluorescence. Now, I must admit, it's difficult to demonstrate the fluorescence here because there is so much autofluorescence in the mouth. And I'm not going to try and convince you that that's going to pick up the fluorescence that well. But I'll show you a little more in a moment. And this is actual delivery. There's the fiber from the laser coming up, going into the mouth. And here there is a little clip on the end of the fiber so the patient can hold the tip of the fiber in the mouth and it can be positioned to aim at the area of the cancer that is being treated. You see the light goes very well through the wall of the mouth. Now, I say this is a little difficult. What has actually happened is there's a lot of autofluorescence in this patient, but if you look just at this area, when you compare that before and after giving the photosensitiser, that is the area where there was increased fluorescence. And what happened after delivering the light, the photosensor is actually bleached out of the treated area, and so that black hole defines the area that's been treated. And you can see this example, here is the actual cancer. You see it's an ulcerated area, and after the treatment, it does take a few weeks to heal up, as I showed you on that lip, but it's all healed up. And in this study, there were 30 patients treated, and we were able to ablate the cancer in 22. Now, this was done with a lot of the standard equipment, and the answer was to say, can we transfer this to do it in the remote village? So modifying all the equipment to be suitable in use small villages, and the LED light source was obviously the most important, and then do the fluorescence study to identify the extent of the lesion. The actual grant application says the idea is we can put all the equipment required on a bicycle. There's plenty of sun in India. We can use that to charge up batteries for all the other things. Anyway, the end of the first part of the project went well. Got funding for the second part, NIH, and then disaster. New inhabitant of the White House, end of project. That's it. Need I say no more? So it's in abeyance, the whole project, at the moment. Now, I'm going to come back to the gastrointestinal tract. I'll show you a bit later why I've just chosen to show this one last rather than first. But actually, most of the treatment, heating hollow organs with photodynamic therapy to try and treat these early malignant changes without causing a full-thickness cleavage, this has been worked out on the esophagus. Because if you look at this, this is the patient. Right down the bottom is the stomach, which is dark red. Here is the pink, which is the normal esophagus. And this is the area where the acid from the stomach has refluxed upwards. And this has it very common. Many people have it. I've had it. But just on some of those, that reflux up seems to stir up a carcinogenic effect. And you can get dysplasia and early cancers developing in that area. And if that happens and you don't do something about it, then the potential will be a full esophageal cancer. Now, before endoscopic treatments were available, you were faced by major surgery, open your chest, cut out the chunk of the esophagus. But if you can distribute the light in a cylindrical metal after a photosensitiser, this is the effect you get. And this is dysplasia of the superficial layer, but it doesn't go right the way through, and it heals up by regeneration of normal mucosa. And the way you get the light in, you can put this balloon in over a guide wire, and then this fiber, which is delivering the circumferential laser light, and put that in, and position it endoscopically where you want. So straightforward, and this is indeed proved for precancer in the esophagus. Now, I should say I haven't said much about different photosensitizers. Well, there are several groups. Oh, excuse me. Some sensitizers you may want to produce a full thickness effect because you have deeper tumours. And in a hollow organ, if it's a focal tumour, it doesn't matter if you get full thickness scarring because we know it won't perforate. The danger is if you do what those original people did in the bladder and treat the whole circumference, and then it will narrow down and stricture. But this is a recognised treatment. Now, this is a patient with a little bit of a history to illustrate some of the problems. Goodness knows how the Daily Mail got onto it, but anyway, that was nothing to do with us. He was one of the first patients treated with this early precancer in the esophagus. And he had it done with that first drug, the one that had come from Roswell Park in Buffalo, New York. And there were two nasty complications that developed using that drug, not actually on this patient. But the first thing was that the drug hung around in the body for ages. And if it was given systemically, like by injection, the skin had to be protected from bright lights. And that went on for several weeks. And hence, saved by the Dracula drug, because of the damage light would expose. And the other thing was this particular drug gave you, or could give you, the full thickness scarring of the esophageal wall, which caused them to narrow. He was fine, he didn't really. But these were both reasons for trying to find a better photosensitizer where you wouldn't hang around for so long and it wouldn't get the scarring all the way through. I'm actually going to show you some experimental work here. I know you don't like it. And I hope you will be able to understand that reasonably simply. This is the same figure I showed you earlier of the 3 layers in the wall of a hollow organ. And imagine it's the esophagus in this case. Now, these were treated, the rats that were treated with 2 different photosensitizers. First of all, the ALA. This is just the untreated one. But when you take the tissue that's been photosensitized and look at it under the microscope, you can excite the fluorescence in the photosensitizer, and it comes out as blue. And you will see with this photosensitizer ALA, all that sensitizer is in the mucosa. That's the top layer. That's where you want it for that selective effect. Go back to that original drug that Malcolm had, which was a HPD, and where does the photosensitizer go? It goes to that middle zone. Now, if you try putting light on each of these, the ALA one, all the photosensitizer is at the top, and that's the layer that's damaged, and you can see the damage there. Nothing further down. With the other drug, the one that gives you effect all the way through, you've got all those layers. So if you want a deep layer, use the old type of drug. If you want the superficial one, use the ALA. Now, here is where, if you mentioned, I said, we knew the biological effect, we should look for situations where that effect could be useful. Well, in the esophagus, and the usually cancer there, that was easy because that had been a problem been known for many years. But I now want to show you another area which I think has potential great selectivity. Now, you might look at that slide. It says type 2 diabetes. Oh my God, he's put the wrong slide in the packet. I don't think you thought you were coming to a talk about diabetes. Well, there's a reason. First of all, let me remind you about type 2 diabetes. This is the one that usually occurs in adults. It's becoming very common. It's related to obesity and lifestyle changes, diet and exercise, and is associated with some very serious complications, heart attack, strokes, and all that. On top of all that, it's difficult to control with the drugs. Now, is there any way around it, and what's the connection with PDT? Well, this goes back about 10 years. Patients who are very obese, and many I say also diabetic, one of the options is what's called bariatric surgery, which is major surgery and which is rearranging the top bits of the gastrointestinal tract. Now let's look at this. This is the normal. this is the esophagus up here. Here is the stomach. And then you go down, round the bend. This is the duodenum. And then the small intestine. This does all the absorbing of your food. Now, in this particular operation, called Rouen way, what has happened is part of the stomach is isolated, and the part that's kept is connected straight to the small bowel, and we bypass the duodenum. Now, you say, okay, that does pretty well for helping reducing weight, but there was an unexpected effect. The patients with the type 2 diabetes, after this surgery for weight loss, the diabetes became much easier to control. And even now, we're not absolutely sure of the mechanisms of that, but it was very dramatic. So the question was, is there a non-surgical way to get the metabolic effect that was achieved with the surgery? And this was just by thinking through the effect on the gut and how it could be applied for another disease. Well, the first challenge, back to the laboratory. Can we destroy the layer of the duodenal wall and preserve the underlying layers, and will the animal survive, and will it have any effect on the sugar metabolism? Well, the answer is yes. This was done, but obviously on open surgery on rats, and it was found, and the rats were fed a lot of fat so that their metabolic situation was like the type 2 diabetics. And amazingly, ablazing that surface layer did help the metabolism of glucose. So then the challenge is, can we actually do this endoscopically and do it in patients? Well, this has been done, and a certain number of patients have been treated, but it's still very much an early stage. And the patient being tried at the moment is incredibly complicated. This is my opinion because I think the PDT is better, but I have to be honest and tell you what the other people are doing. Now, look here. What happened? The aim is here, you want to separate this layer and destroy that, but leave this one intact. Now, this was not tried with PDT, but literally had little needles in this big balloon which was put into the duodenum and injected saline, that salt solution, through the top layer to separate it from the underlying layer. And then, would you believe, to destroy the top layer when it was separated, they did it by putting very hot water down the side of this balloon. Well, and this is what you got. You had to put these two things down in the duodenum together. You'll see the endoscope is the black bit, and this balloon is the pale bit. Well, in all fairness, it can be done, and it does produce the changes. But it just struck me, it's an awful lot simpler doing it with PDT. I showed you in the last slide how you can destroy that top layer on its own, especially if you use ALA as the photosensitiser. Now, what would that involve in the duodenum? A glass of fruit juice with the drug in it, a standard endoscope that any normal general hospital is going to have, a fibre connected to a laser which has got bright light on the end, and you shine that light inside the duodenum. That's basically it. Now, I stress this has not been done in patients at the experimental phase, but the principle looks very promising. The idea of using PDT to treat type 2 diabetes is exciting, but that's a future thing. Let's move on to other things which are more established. Oh, a complete change from diabetes. How about brain tumours? Now, the glioma, many of you probably know, is the most malignant brain tumour. Unfortunately, usually the most common brain tumour. And the standard management is to remove as much as you can at surgery and then follow with chemotherapy and radiotherapy. Well, look at this picture. First of all, the one on the left. The surgeon has opened the brain and he's looking at the area where his scan has shown us the tumour is. Can you see where the tumour is? Well, surprise, surprise. Give the photosensitizer, activate with blue light and look for the pink bits of tumour, and there you are. There you are. Tell the surgeon where to go. he can be much more accurate in his resection, because obviously he doesn't want to take out any bits that might be normal brain. And if he can't tell whether it's brain or normal, then he has to be very conservative. But what this means is, well, it's photodiagnosis, obviously, but it's called fluorescence-guided resection to pick up the exact extent of the tumour, at least the massive parts of it. And this is now standard practice, and this is one of the big developments for photodiagnosis over the last 10, 15 years. But in this patient, you know you've got photosensitizer there, and the surgeons removed the bits that are obviously solid tumour, but cancers don't behave like that. They infiltrate places. And even though many of these patients are routinely given radiotherapy and chemotherapy, there's still a nasty habit that they might spread further. Well, the first thing is, this has had a photosensitizer. Can't we use that photosensitizer for PDT into the bits we thought were normal brain, but have bits of tumour lying around? Well, there are trials underway to see if this works. And they're putting fibres into the brain in all sorts of different ways. You can put this balloon into the cavity that you've made for the operation and put a light in that. Or you can go directly putting other needles into the normal brain. I can't help feeling, and every time I look at this picture, this is getting a bit excessive. 6 needles going into a brain to get fibres in the right place. Well, anyway, they did. We don't know the results of those trials. I know they're being undertaken, some in Japan, some in Germany, some in the US. But there's still another problem. These gliomas are notoriously recurrent. Even if you get the bits in a few millimeters away from the treated area, some cells escape even further. And the problem is, if you don't know where they are, how can you treat them? And that's very difficult with PDT. You can't diffuse the light through the whole of the brain. So here's another little project we've done over the last few years. How about bioluminescence? Instead of having to deliver from the light from the outside, let's actually create the light on the cancer cells. Now, clearly, this is a big challenge. You'll all be aware that lots of marine mammals or creatures can produce light. But the best one outside the sea is firefly. And you can see there's even enough light there to actually just read a little bit of printing. Anyway, what we did was took human malignant glioma cells, transfected them with the enzyme luciferase taken from the fireflies, and then we create a system which can generate light in the cells. Now, the principle of light generation is you need 2 vital things. You need luciferase, which is the enzyme to convert luciferin, which is the substrate. Neither of these exist in mammals. But you can transfect the luciferase, which is what we did in the glioma cells, and then transplanted them into mice. And then we could give the luciferin, which is the substrate, which is activated by the luciferase. And that gives you the light. But then, of course, you can inject the photosensitizer, but you can do that by another separate injection. Well, I hope that's not too complicated for you, but the message is that if we could get the luciferase into the glioma cells, we could actually treat these tumours in mouse brains. And here you see this is an untreated tumour in a mouse brain, and you see all the brown spots, that indicate living cells, but the treated one, they've all gone. Normal brain tissue does not multiply in the brain, so you see there's no staining there. So this is tempting to move into a new area, but just one interesting point from the physics point of view, you've got to match a light source with a light absorber. There's an absorption spectrum for the photosensitizer you're using, and an absorption emission spectrum from the bioluminescence from the transfected luciferase. And you'll see in this case the two don't match up very well. But for future developments of this, obviously you want them to match as well. Then you're going to get the most efficient effects. Interstitial PDT in solid organs. Now this is a big challenge because, as I mentioned earlier, you've got to see if you can get light to travel through solid tissue. Red light and a good transmitting tissue, yes, you can treat a reasonable volume. And less transmitting organ and different colour, and it won't work. The challenge is to get the adequate fluence of light at the point in the tumour furthest from the light source and get that up to the threshold level. And if you can do that, then you stand a chance of getting the whole tumour. Now, this is a real challenge. This is, we have to admit, pilot studies. We did about 5 years experiments on hamsters transplanting cancers into their pancreas and showed that we could treat those and even eliminate them and increase their survival time. And we felt brave enough to try it in patients, which we could do. And we've shown that it can be safe in patients, and we used this technique of 4 needles, laser fibers going through the needles, and then guided with this CT scan, so the patient is in a CT scanner. This is a plain picture of the needles going in, and that black area is the area of necrosis or discrosed tissue in the tumour. So it's there, but the challenge to get a big enough effect that's going to challenge the prognosis of this very nasty cancer is a long way ahead. Just to give you an idea of the scale of PDT research, this patient was treated more than 20 years ago. And we haven't got much further because nobody's thought of the way of treating enough to really help the patient. You can do the same in the prostate. Quite extensive studies have done of the effect of PDT in the prostate, where again you give the drug by injection and you put the needles in again through with ultrasound control into the prostate. It does work. Yes, we can destroy isolated areas, but it's a long way. That's an untreated one where the biopsy proved the ulcer and then the black necrotic area. So I must admit it's a bit doubtful whether this is ever going to get established. But possibly if you've got a local recurrence after radiotherapy, there may be a role. But this is one area where it's been much more promising, the head and neck. You can imagine how difficult it is to try and operate on cancers in the back of the throat and what sort of a terrible mess the whole area is going to be if you can't get it adequately. But here, with very careful guidance, if you put the fibers in, you can project, you get local necrosis in tumours in that area. And you have to keep your fingers crossed that it's going to work this time. Let's see if we can show you what will happen here. Here we go. Patient on this side, line for the lasers mapped very carefully with the imaging. Fibers put through the needles into the tissue. It's in here. They get a fiber down each needle and wait for it. Just wait for the light to go on, and there you are. Now this, as far as the patient's concerned, I was actually present at that procedure. The radiologist, who's the one who plans exactly where to go, put the needles in under ultrasound control, because he already knew from the more sophisticated CT and MR scans exactly where to go. And that was what the patient had. There were no big holes anywhere, no knives anywhere. Now, in all honesty, you're not curing patients at the moment because it's not sufficiently accurate. But people with massive tumours in that area, if you can debulk them by this technique, the symptomatic release is wonderful. And you get the occasional one in which it's long-lasting. So this is something way things might go in the future. Now I'm just going to give you a few examples of other areas where PDT is being assessed, although not necessarily in routine use. And this is the cervix. For ladies who have abnormal smears on their cervix, the idea is you might be able to treat that with PDT. This is an example of a cervix which has fluorescence from the photosensitiser. And then this device, where you put the photosensitiser in this little cup, which can be fitted over the cervix, and this device underneath, which about 3 or 4 hours after you've put in the photosensitiser, it's got a bright little light on that, which shines like this, done automatically, and that activates the cervix where the photosensitizer has been absorbed. This is so inherently simple. It's developed by a company in Norway, and it's a guy in Germany who's doing the main trials on this. But the real point is, if this can produce the desired effect, it's a very simple treatment for an abnormal smear. And it's so convenient for the patient. You can walk in, have the thing fitted, only come back a day later to have it taken out again. And I should add, this sort of approach is also suitable for other areas in the regions around the perineum, where it's a bit similar to the effect on the skin. You can get the destruction of the cancer cells and healing of normal tissue close to normal. Now, perhaps the best future for PDT is in immunotherapy. And immunotherapy is stirring up the body's immune system. Obviously, untreated cancers do not stimulate an immune response. Well, if they did, the cancer wouldn't grow, so there wouldn't be a problem. But this is one simple experiment. We're back to the old mice again, a little tumour on them, treat with PDT, abolish the tumour. Then try and inject that original tumour again to make it grow again, won't grow. So the mouse has, the first treatment, somehow, we're not quite sure how, has activated the mouse's own immune system to fight against that cancer. And when you try and put the cancer in again, later, it won't grow. Now, obviously it's an early stage of investigation, but essentially it's a very, very promising area. PDT has effectively vaccinated the mouse against its own previous tumour. Now, a few other quick ones. Infection. This is going to be a major application of PDT. The essential thing is you get the photosensitizer actually onto the bugs, whether they're bacteria, viruses, perhaps even fungi of various sorts. And this is a particularly good example. We've all got little bugs growing up our noses, and most of the time they don't cause any trouble. But sometimes, if they escape as part of another Prager operation, then that can be deadly. You've probably heard of the MRSA, which is the bug that's resistant to so many antibiotics. Well, just look at this concept. What's effectively a cotton wool bud soaked in methylene blue, which is another photosensitizer, and gently placed up each nose. And then just a few minutes later, have another device, which has got two fibers, very soft, so it can put it up your nose, which can deliver light here. And there you see, there's another way of having a red nose. But potentially, you can clear of infections there, which previously screened people prior to surgery to see if they got these bugs and gave them a course of antibiotics to clear them. But now you can do it, in a matter of not more than minutes, quickly and easily. It's developed by a Canadian company, and it's very popular in Canada, I know, particularly among orthopedic surgeons. Now, what about using PD when you're not even near a patient? The concept here is if you can fix the photosensitizer somewhere and then apply light, you may kill bacteria on infected surfaces. And one idea here was to do this on the keypad on the laptop. You build the photosensitizer into a layer on the top there, and eventually if you want to disinfect it, you just turn the lights on. But you've got to make sure that you're getting light of an appropriate wavelength. Now, once again, this is back in history. Age-related macular degeneration is the commonest cause of blindness in this country. Now, you say, ridiculous, what's that got to do with PDT? Well, actually, PDT was the first approved treatment for AMD. 25 years ago first. And the reason was, it's nothing to do with cancer at all, but it's leaky blood vessels that cause the AMD, and if you can just close them down a little bit, which you can see between the before and after pictures, it doesn't cure the disease. What it does is slow down the progression. And this is, of course, a major advance for these patients, whose sight may deteriorate to nothing over a period of years. If you can give them a few extra years of being able to see safely, then clearly that is critical. Now, one final one, not even anywhere near a hospital, mosquito bleeding control. If you spray photosensitizer over larvae growing mosquitoes in the night, when the sun comes up in the morning, the larvae ingest it and then they die. Now, I hope they're not going to cut me off before I just give you a quick reality check. Why PDT? It's different from the other means. It avoids cumulative toxicity. It's complementary to the other things. It's difficult to do trials. Potential future. Immunotherapy, perhaps the diabetes, perhaps infections. A stress, the medical community is very reluctant to change. These cows, typical of some obstinate obstetricians, obstruction relieved by the gentle advance of an eminent PDT physician. My way of thinking about PDT, a gentle way to get rid of nasty bits of tissue without upsetting all the nice bits. And look at the bottom, at the cutting edge of medicine, without any cutting. I haven't mentioned a knife through all these mentions. So it's a physician's treatment, not a surgeon's treatment. Of course, you get into trouble if you try and do too much. But I hope I've shown you that there are ways of anticipating the trouble and not getting it there. There's an international organization, International Photodynamic Association, been running since 1986, that's 40 years. Have a conference every 2 years. Last one was in Shanghai. 600 participants. This is a big topic in global interest, although in all fairness, it's dropped off a bit in this country, but elsewhere it hasn't. Just to show you, the London, the UCL Medical Laser Centre is very enthusiastic about going to conferences. And this is all about the people who have been related to the unit over a few years who gathered at a conference. This was in Europe somewhere. And finally, this was the 25th anniversary dinner of the Medical Laser Centre in UCL. Lasers and PDT have kept me happy for 40 years, and I hope they will keep many people happy for the next 40 years. Thank you very much.